Welcome to this lecture on PET-CT imaging for neuroendocrine tumors. This focuses on gallium-68 and copper-64 tagged somatostatin analogs, and the zebra is the mascot for neuroendocrine tumor awareness, and so that's why this lecture is zebra print themed. These are the objectives. So what is somatostatin? It is also known as a growth hormone inhibiting hormone or somatotropin release inhibiting factor or somatotropin release inhibiting hormone. Essentially, it's kind of like the hall monitor of your hormones. It's going to regulate the endocrine system, and the release of somatostatin is partially triggered by a low pH. The pituitary gland, somatostatin will inhibit the release of growth hormone, thyroid stimulating hormone, and inhibit the adenylyl cyclase in parietal cells, and it inhibits the release of prolactin. In the gastrointestinal system, it inhibits the release of gastrin from the parietal cells. The cytokinin, which is our cholecystokinin, which is CCK, secretin, motilin helps with gastric motility. The vasoactive intestinal peptide, gastric inhibitory polypeptide, and enteroglucagon. So it has a lot of effects on regulating the hormone secretion of the GI system, and it can decrease the rate of gastric emptying as well as reducing smooth muscle contractions and blood flow within the intestine. In the pancreas, it suppresses the release of pancreatic hormones, insulin, and glucagon. Neuroendocrine tumors are sometimes called somatostatin recepting tumors. The tumors have a large number of receptors for somatostatin, so typically what happens is because somatostatin receptors are already present on neuroendocrine cells, when those cells become malignant, because the somatostatin kind of inhibits their production of hormones, typically neuroendocrine tumors are functional tumors. They will overproduce whatever hormone that those cells normally produce. And so they will naturally develop more somatostatin receptors on the surface of those cells because your body is trying to regulate the overproduction of hormones. And so neuroendocrine tumors have a large number of somatostatin receptors on the surface. And somatostatin analog drugs are sometimes used for treatment of neuroendocrine tumors, or at least for the control of the patient's symptoms. Octreotide is a somatostatin analog that is used over the counter, or not over the counter, but prescription for treatment for neuroendocrine tumors. And it essentially just blocks those receptors and it suppresses the function and proliferation of the cells. We also have octreotide, which is an indium-based general nuclear medicine agent that has traditionally been used to image neuroendocrine tumors before these somatostatin agents came along. These drugs can also be tagged to an isotope for diagnosis and staging of neuroendocrine tumors. So these are areas where neuroendocrine tumors are generally found, and neuroendocrine tumors are typically classified as foregut, midgut, hindgut, depending on their embryonic origin, and the pancreas has at least 5 different types of functional tumors. I will point out that the lung is included in the foregut, as is the thymus. Those are not necessarily part of the GI tract, but because of their embryonic origin, they're considered foregut. So the foregut ones are thymus, esophagus, lung, stomach, duodenum, and pancreas. In the midgut, you have the appendix, small bowel, cecum, and ascending colon. And in the hindgut, you have the distal large intestine and the rectum. Now, the pancreas neuroendocrine tumors, there are, as this says, at least 5 different types. And the common ones that we would see are insuloma and gastrinoma, but you can also see vipomas and glucagonomas, as well as pancreatic polypeptidomas. So each embryonic division has its own blood supply. That's how it gets that classification as foregut, midgut, or hindgut. So in the foregut, it goes from the esophagus to the duodenum at the level of the major papilla. So this consists of esophagus, stomach, proximal duodenum, liver, gallbladder, pancreas, and spleen. Now, neuroendocrine tumors have that high overexpression of somatostatin receptors. So these are just a short list of the ones that will overexpress gastroenteropancreatic tumors, and that's all the ones I just listed in the pancreas: carcinoids, gastrinomas, insulomas, glucagonomas, vipomas, etc. Functioning and non-functioning sympathoadrenal system tumors, so from the adrenal glands, pheochromocytomas. Paragangliomas are essentially pheochromocytomas that occur outside of the adrenal glands. Neuroblastomas, which are typically but not always kind of located from the brain. Ganglioneuromas, medullary thyroid carcinomas, pituitary adenomas, medulloblastomas, Merkel cell carcinomas, small cell lung cancer, when these are primary tumors, and then meningiomas, which is occurring in the brain. So in the foregut, we have small cell lung cancer, the gastroenteropancreatic tumors, and functioning and non-functioning sympathoadrenal system tumors like the pheochromocytoma. Carcinoid is worth mentioning. This is also called carcinoid tumor. This is a slow-growing neuroendocrine tumor originating in the cells of the neuroendocrine system. It is mostly asymptomatic until it's not anymore. If the symptoms persist, symptoms are caused by oversecretion of hormones in the endocrine tissue that's affected. They most commonly originate in the GI tract or the lungs, but they can be found anywhere. Common symptoms include flushing, diarrhea, wheezing, abdominal cramps, and peripheral edema. And metastases will lead to carcinoid syndrome. Carcinoid syndrome is caused by the endogenous secretion of mainly serotonin and kallikrein. Patients usually have a hyperhistamine response, including serotonin. This will lead to liver disease and other symptoms as the liver becomes overwhelmed trying to process the excess histamine and serotonin and in the bloodstream. And then this will lead to asthma and restrictive cardiomyopathy as well. The most sensitive and specific exam for carcinoid syndrome is the Octria scan at about 90%. CT and MRI are only about 70 to 80%. This is being replaced by gallium-68 dotatate octreotide, which is effective as well. And patients are evaluated for peptide receptor radionuclide therapy with lutetium-177. Yttrium-90 has been used in clinical trials for that. And then also patients can be evaluated with the indium-111 labeled 2 octreotide. Part of the problem with neuroendocrine tumors is that the symptoms are kind of systemic and not real specific to the type of cancer because it has to do with overproduction of hormones. It can affect a lot of different body systems and functions, and sometimes it can be rather asymptomatic for a period of time. But these are fairly common symptoms that you would see, especially with carcinoid, is the liver hepatomegaly, hepatomegaly. In the gastrointestinal tract, diarrhea, cramps, nausea, vomiting. With the respiratory system, cough, wheezing, and dyspnea, facial flushing in the skin, and then pulmonary and tricuspid fibrosis within the heart. In nuclear medicine, there's quite a few things we can do for neuroendocrine tumors. We in nuclear medicine are a little bit better at imaging neuroendocrine tumors than other imaging modalities because these are functional tumors more than structural. And so we're going to see them a lot sooner just based on what nuclear medicine can do. So with general nuclear medicine imaging, we have indium-111 octreoscan, also known as pentetriotide, and this is a somatostatin analog that's designed to bind to the somatostatin receptors. The I-131 MIBG is also used in general nuclear medicine, and this is also known as iobenguane or meta-iodine benzylguanidine. And this is similar to noradrenaline. It binds to the adrenergic tissue. It's capable of releasing epinephrine, and it's great for imaging pheochromocytoma or neuroblastomas, not as good when we're looking for other neuroendocrine tumors. I-123 MIBG is the same thing. It's the same iobenguane, but tagged to I-123. That has better imaging qualities just because I-123 is a better imaging agent than I-131. And then we have, with the PET agents, gallium-68 dotatate, Dotatoc, or Dotanoc, depending on the company producing the drug, or copper-64 dotatate, also known as DetectNet. So copper-64, as you recall, is cyclotron produced. It may be produced in a reactor, but typically it's cyclotron. The decay scheme is up here to the right in the right-hand corner. It decays by electron capture and positron decay, and it will eventually decay to stable nickel. It decays to stable zinc. This is the only FDA-approved copper-68 dotatate drug, and it is linked to a variety of bioactive molecules that can be used for several things, but the only thing that is commercially available is the copper-64 dotatate. So this is from the package insert for DetectNet. As you can see, like I said, it decays by positron, beta, electron capture, and gamma. It has kind of a messy decay. It binds to the somatostatin receptors with highest affinity for subtype 2 somatostatin receptors. It binds to cells that overexpress somatostatin receptors, including malignant neuroendocrine cells, and somatostatin analogs do completely bind to the same somatostatin receptors as copper-64 dotatate and may affect imaging, and therefore patients should be withholding their somatostatin analog drugs until after imaging. Administration for this, patients are given about 4 millicuries. And imaging begins 40 to 90 minutes after the drug administration, and it's a whole body acquisition from the skull vertex, which is the top of the skull, down through the mid-thigh. Because there are a lot of neuroendocrine cells within the brain, it is important to also scan the brain, so that's why these patients go from the top of the head down through the mid-thigh. It is stored at normal room temperature. And the critical organ is liver, kidneys, adrenals, and the spleen. Areas of normal uptake are really anywhere that neuroendocrine cells exist, anywhere that there are somatostatin receptors, although it will take up with a greater affinity for any areas that have somatostatin recepting tumors. This is an example of indium-111 DTPA, which is the general nuclear medicine imaging agent that has traditionally been used for neuroendocrine tumors. It does not have great image quality or imaging qualities because it is indium and it has a longer half-life. You use a lower dose, that kind of thing. The spatial resolution is limited by the regular gamma camera, but with PET, you have increased spatial resolution, and that copper 64 has great imaging qualities, and so you really do get great images. And that is the same patient with multiple bone and soft tissue metastases. So you can see the benefit of PET for finding those neuroendocrine tumors because there are a great deal of them that got missed by indium, especially if you look at the head and the skull, or even around the back and the arms, in the GI tract. And so you can clearly see in this one that the PET with copper 64 dotatate is a better option for patients than the indium study. Next, we have the gallium-68 for those agents. So recall that the half-life for gallium is 68 minutes. It is generator produced, although it can be produced in a cyclotron if needed. And it is typically produced from zinc. With the gallium-68 somatostatin receptors, it is tagged to a somatostatin analog, and it localizes in somatostatin receptor positive neuroendocrine tumors. The method of localization is receptor binding. This is a package insert. You have gallium-68 dotatate and dotatalk. So this is just a generalized information for dotatate, but it binds to the somatostatin receptors with high affinity for subtype 2, and method of localization is receptor binding. You will see the decay of gallium-68 is predominantly positron, but it also has X-ray and Auger electron emission, as well as 13 different gamma transitions. And then contraindicated, of course, in pregnancy or nursing. This is not an absolute contraindication. So if the patient does need to have the imaging while they are pregnant or nursing, they can do that, but precautions would need to be made for that. It is administered intravenously, and the typical dose is about 5.4 millicuries. And there is a calculation there for weight-based dosing. It is stored at room temperature. It expires typically within 4 hours. Critical organ for this one is the spleen. And the normal biodistribution is pituitary, thyroid, spleen, adrenal glands, kidneys, pancreas, prostate, liver, and salivary glands. There's no uptake in the cerebral cortex or in the heart. And usually there is some uptake in the thymus and the lung, but this should be very low uptake. So what is the difference between all of these different neuroendocrine agents? Well, gallium-68, dotatalk, also called Actevi, this one is FDA approval pending. It may be FDA approved by the time you're watching this video. It binds to the somatostatin 2 and the somatostatin 5 receptors. And so it's anything that overexpresses either one of those will show up. With the gallium-68 dotatalk, it's believed to be a little bit more sensitive to neuroendocrine tumors because it will bind to somatostatin receptors 2, 3, and 5. Now, typically when it binds to more of the more receptors it binds to, the less increased activity there will be when a tumor is found. And then with the gallium-68 dotatate, also known as net spot, this one only binds to the somatostatin 2. but it has a 10-time higher affinity for the somatostatin 2 receptors than the other agents do. Gallium agents in general will have a lower dose than the copper agent. They will also have a lower background uptake, so they'll have a better target to non-target ratio, and they also have a faster uptake from the bloodstream into the neuroendocrine tumors. Now, copper 64 dotatate, also called DetectNet, that one only binds to the somatostatin 2 receptors also, and that's because it's still dotatate. Notice both of those are dotatate, and so it's the same dotatate, just tagged to a different isotope. So the DetectNet, the copper 64, will also have a higher affinity because it only binds to somatostatin 2 receptors. Copper 64 dotatate has a lower effective positron range, so theoretically it will have better spatial resolution and a higher SUV max for better quantification of the tumor or the metabolism of the tumors. And they have less labeling time but higher labeling efficiency. So you have a little bit purer of a drug when you're getting the copper 64 dotatate, but it does require a higher dose to get the same scan counts because it has a longer half-life. And so you're giving the patient a much higher radiation dose when you're using the copper 64 dotatate. Another advantage of the dotatate is that because it has a longer half-life, it's a little bit easier to obtain and a little bit better commercial availability in areas where it's a little bit further from a cyclotron because it has the 12-hour half-life instead of 1 hour essentially. But you are giving a much higher dose to the patient. So again, copper versus gallium. The half-life is 12.7 hours of copper versus 1 hour for gallium. And that makes it better when you are far from a cyclotron, a little bit better commercial availability when it has a longer half-life because it can be shipped a little bit further. The positron energy is 64 MeV for copper and 1.9 MeV for gallium. So gallium has a higher energy. The mean positive range is a big deal. The mean positive range for copper is 0.56 millimeters, but for gallium it's 3.5. If you look at that, those last two bullet points I just mentioned, what's happening there is that the copper has less energy. The actual positron coming from the nucleus has less energy. And so it's not going to travel as far from its source, from its atom before it annihilates. And so that's why it won't travel as far, right? Less energy, it won't travel as far. So the copper has less energy, it stays closer to the initial nucleus that it came from before it annihilates. And that means it has much better spatial resolution. You have a better ability to see where that tumor came from, where it originated from, because it's not going to travel as far. Whereas with the gallium, it has a much higher energy, which means that positron is going to travel further before it annihilates. And so you end up having less spatial resolution because the positron will travel further before it annihilates. And then the radioactive decay, though, is sloppy with copper. Copper releases a beta negative and a beta positive, so an electron and a positron. And then also it has electron capture, which is going to ultimately give off a gamma. Whereas with the gallium 68, there is no beta decay. It is 90, almost 90% positron, and then 11% electron capture. So you're going to have a lot more counts coming off of the gallium than you will from the copper. So this is comparing them also. Lower energy means a shorter positron range, which provides better spatial resolution for PET. So if you look at this middle here, this is showing you how far that positron will travel from the nucleus before it annihilates, and how that affects the image quality or the spatial resolution. Whereas with gallium, it's going to travel further from the nucleus before it annihilates. And so these lesions that are very small, you may not pick up at all with the gallium, but you will find with the copper. And then when you have 3 small lesions grouped together, they're more likely to show up as 3 small lesions grouped together with the copper, whereas it would show up as one larger lesion with the gallium. So these are the normal biodistribution, copper versus gallium. They do have a very similar biodistribution. There is less splenic uptake in the copper 64 dotatate, and that has to do with just because of the copper part of it. So copper is more sensitive, but it requires a higher dose and it has a longer half-life, and the spatial resolution is different. Gallium is less sensitive, but then it has a different positron effective range. So that's where that becomes very important to see that effective positron range. So indications for neuroendocrine tumor imaging, initial staging at the diagnosis. It's used to localize primary tumors, staging before surgery, before or after or during treatments, selection of patients for peptide receptor radionuclide therapy. That's that lutetium 177 therapy for neuroendocrine tumors. And then post PRRT therapy, it's used to study, it's done to serve as a new baseline for 9 to 12 months after the completion of treatment so that future studies can be compared to that one as the new baseline. Some neuroendocrine tumors will have lower expression of somatostatin receptors, and therefore imaging with FDG would be more beneficial. Really, patients should have both. They should have the neuroendocrine study and they should have FDG, because remember, as tumor cells progress, they will become more and more heterogeneity, less homogeneous, and so you will have some that are just cancer cells at that point, just taking up sugar, and you will still have some that are neuroendocrine cells that are taking up somatostatin. So it is important for patients to get both, especially as the tumor progresses. Those FDG studies will be more and more important. Neuroendocrine neoplasms are broken down into neuroendocrine tumors and neuroendocrine carcinomas. You will have a loss of somatostatin receptors as it progresses to carcinoma, and the loss of somatostatin receptors and uptake on FDG may indicate that there is a progression of the disease. So if you're seeing that you see less and less tumors, less and less uptake in tumors on the neuroendocrine study, but they're taking up more activity on the FDG, that's a sign that the tumor is progressing and that the cancer is progressing quickly. Patient prep for the neuroendocrine tumor imaging, discontinue the short-acting somatostatin analogs for 12 hours. Long-acting somatostatin analogs need discontinued for 3 to 4 weeks. The patient should be instructed to drink water, be well hydrated, and void frequently. This is safe to use on pediatric patients, but sedation may be required. And if the patient is breastfeeding, they should be instructed to discontinue that for 24 hours post-injection. Now, the dosage is very dependent on the radionuclide that's being used. For gallium-68 DOTATOC, it's 4 millicuries typically, but the range is 3 to 5. For children, for that one, it is typically a weight-based dose. DOTA-NOC is very similar to DOTA-TATE. DOTA-TATE for gallium is about 5.4 millicuries, but there is a weight-based calculation for that as well. And then for gallium-64 DOTA-TATE, it is a dose of about 4 millicuries. There is also a slightly different uptake time based on the radiopharmaceutical being used. For gallium-68 DOTATOC, it's 55 to 90 minutes. For gallium-68 DOTATATE, it's 40 to 90. And for copper DOTATATE, it's 45 to 90. Now, that is only varying slightly, and a lot of that has to do with the different drug companies did their own clinical research, and that's what they came up with and recommended. But it's all very similar. In the real world, most people will wait about an hour before they start scanning. So copper 64 does have a longer half-life than gallium. So a later imaging time point with copper is feasible if needed, but it is not necessarily feasible for gallium. So that's one reason some people prefer copper over gallium, is just because it allows a little bit more flexibility in their schedule if they get behind schedule. During uptake, the patient can eat and drink whatever they need to. Some protocols require administration of low osmolality or oral contrast if the patient has a gastrointestinal neuroendocrine tumor. Typically, that is a very low osmolality contrast or water, and that's just used to kind of help separate what's neuroendocrine uptake and what isn't. Scan is done. A scout CT is done, and then a CT if needed, and then the PET. The scan is typically from the vertex, which is the top of the head, all the way down to mid thighs. But some neuroendocrine tumors will require imaging the whole body, or the doctor may request that based on the tumor suspicion. In the case of liver metastases, a diagnostic CT with IV contrast is very helpful. If IV contrast is given, water should be used for oral contrast instead of the low osmolality contrast. The scan is typically vertex to mid thighs. Position the patient supine with their arms above their head. They are usually scanned in 3D mode with about a 3-minute bed position. You may need 4 to 5 minutes for copper. Because copper has a longer half-life, you will have less photons coming off of the patient. Therefore, you'll have a lower count rate. And so you'll need to increase your time per bed position. That's a little bit of a disadvantage for copper. And I do want to preface that bedtime is very dependent on the scanner type. If you have an older scanner, you'll need more time. If you have a newer scanner or a digital scanner, then you will need less time per bed position. And then typically the reconstruction is done in 2 millimeter slices and the sagittal, coronal, and axial views. This is the protocol at a glance for somatostatin imaging. The preparation, no slow acting somatostatin analogs for 12 hours, no long lasting ones for 3 to 5 weeks. Patient can eat and drink whatever they want, but they should be well hydrated. Administration for DOTATOC is 4. DOTATATE could be weight based or 3 to 5 millicuries. And then gallium-64 DOTATATE is about 4 millicuries. I have even seen up to 5.5 millicuries for the gallium DOTATATE. During that uptake period, encourage the patient to hydrate. They may have a low iodine, low osmolality oral contrast that may be given for, in the case of gastrointestinal neuroendocrine tumors. Uptake will take about 45 to 90 minutes. It's very common workflow to, at 60 minutes, get your patient up, have them use the restroom, and then put them on the scanner and scan the patient at 3 minutes per bed position in 3D mode. If you're using copper, you may need to increase that. If you have a digital scanner, you may be able to decrease that. And then usually this is vertex to the thighs with scalp, CT scan, and then the PET. Normal biodistribution for somatostatin recepting tumors. It is most intense in the kidneys and bladder, spleen, and liver. Normal uptake is also seen in the pituitary, adrenal glands, salivary glands, and the thyroid. Copper 64 dotatate allows for late imaging. At about 3 hours after injection, the dotatate with copper uptake decreases for kidney and bladder, remains unchanged for the spleen, and increases in the liver. So if you're doing late imaging with the dotatate, it does alter the biodistribution just a little bit. But there are no major differences between the physiologic uptake of copper 64 dotatate and gallium 68 labeled dotatate, especially at the 1 hour mark. So this is gallium 68 dotatate, gallium 68 dotatate in the middle, and then copper 64 dotatate on the end. Now, part of the reason that copper looks like it's a little bit less intense is because you have less counts coming off of the patient, and so you have less counts in the image than you do for the gallium agents. But if you notice, you do have better spatial resolution for what you can see. So images should be interpreted by a physician that's trained in somatostatin recepting tumor imaging, and informed about the clinical context of the scan, staging, assessment, restaging, all of that. Focal tracer uptake that cannot be explained by physiologic biodistribution or that is higher than the organ background activity is to be considered pathologic, especially if there's a correlating abnormal structure on the CT. And consistent qualitative grading of the uptake, mid 5 blood pool, moderate 5 liver, intense 5 examples can be used in addition to the SUV related measurements and a modified Krenning score. The Krenning score is often used and sometimes more heavily weighted than SUVs when you're looking at neuroendocrine tumor uptake. This is a proposed semi-quantitative method of assessing the degree of tracer uptake. And relative uptake score 0 would be none, and then it progresses to 4, which would be uptake that's greater than the spleen. The commonest contemporary application of the Krenning score is to assess candidacy for peptide receptor radionuclide therapy using lutetium-177 dotatate, usually in patients with a score greater than 2. False positive localization in general somatostatin scintigraphy may be as high as 12%, and therefore scoring and interpretation should take place in appropriate clinical context where multiple things are assessed to determine what their score is. And eligibility for PRRT is dependent on the Krenning score. There's another one called the SSTR RADS score. 1 to 2 is likely benign. 3A to 3D is considered equivocal. These are patients with a high likelihood of a neuroendocrine tumor, but the scan is equivocal or negative. Patients should then receive an FDG scan in case the cancer has progressed to heterogeneity. And then 4 to 5 are positive scans, and the patient is a candidate for PRRT therapy. If you're using gallium-68 or copper-64 for the first time, you do need to prepare your dose calibrator, scanner, and hot lab to accept counts from there. In order to prepare your hot lab, you would need to make sure that your dose calibrator is programmed to measure the gallium or the copper. If you're using copper, you also need a longer decay hot trash to store your copper because it will decay a lot slower than the F18 or the gallium. And the scanner needs to be calibrated for gallium or copper, especially for SUV calculations. And typically a physicist can help with that, and the scanner manufacturer would probably have recommendations for that as well. Now, if your site has never imaged with copper-64 previously, like I said, you have to prepare the dose calibrator, the hot lab, and the scanner prior to receipt of the first dose. The scanner, verify that the scanner has the copper-64 radionuclide option. If not, the manufacturer can help with adding it. The half-life is 12.7 hours and the positron fraction is 17.6. Those are important for preparing the scanner. You'll need to create a scanning protocol for using copper-64. And then this update allows all of the corrections and reconstruction to take place appropriately with the isotope characteristics. If the scanner also requires a well counter correction, you do not need to have a separate one for each isotope. So that's something that you would not need to do. A normal variant is to see activity in the thymus. This is due to expression of somatostatin receptors on the thymic lymphoid tissues. Another one is the splenial. Splenials will demonstrate intense uptake of gallium somatostatin receptors. This is most common in perisplenic location, and it should be stable compared to prior imaging. If diagnostically challenging due to a lack of prior imaging and unusual location, then a second test of 99M-Tech sulfur colloid or heat damage red blood cell scan may be performed to rule out whether or not that is a somatostatin recepting tumor versus a splenial. Most commonly, that would be done with the sulfur colloid scan, as heat damaged red blood cells are not used as much anymore, but either one would be acceptable. So this is a 60-year-old man with pancreatic neuroendocrine tumors and focal uptake in the pancreas with no metastases. The arrow there is pointing to the focal uptake in the pancreas. This is a 90-year-old with metastatic neuroendocrine tumor of unknown primary. So by the time they found it, it was already metastasized. They're not sure what the primary is at this point of this scan, but small bowel primary tumors are often very small, and the somatostatin receptor tumor imaging is often helpful to identify them. There's one located there by the arrow. And additional extensive liver and retroperitoneal nodal metastases are also seen. So this is where you see them extensively in the liver. On the transaxial images you can see here, I like to point it out on the fusion imaging because that helps you see that kind of red there is the outline of the liver. And then you see all these kind of white yellowish areas are the tumors. And then retroperitoneal, you see kind of up here in the rest of the kind of abdomen there. This is a 70-year-old man with progressive metastatic small bowel neuroendocrine tumor. And this person was being assessed for eligibility for the lutetium dotatate therapy, and is based on all lesions demonstrating high somatostatin recepting expression above the liver background, and as in the patient's extensive liver, you see down here in the liver, and the lymph nodes, you see kind of up here, and even some bone metastases, which is not necessarily that present here in these images. Patient should also have progressive graphically or clinically to kind of assess that a little better. And you can see here all the uptake in the patient's liver. So this is the CT by itself, this is the PET by itself, and then down here you have the fused images. Now here's an example of MIBG versus dotatate. Recall that I-123 or I-131 MIBG are often used in patients with pheochromocytoma or paraganglioma. And this is a patient with a history of mutant paraganglioma. The I-123 MIBG study does not show anything, but when the patient received the copier 64 dotatate study, you see extensive uptake of neuroendocrine tumor and essentially paraganglioma. And this is a patient with a partial response to the lutetium dotatate therapy. The first image there on the left is a gallium-68 dotatate study from March of 2020. They received the therapy and then followed up with a gallium-68 dotatate study in December of the same year. And you see that there is a little bit less uptake, but there is still the presence of neuroendocrine tumors and somatostatin recepting tumors. And then the last one here, this is carcinoid syndrome pre and post therapy. So in image A, that person had carcinoid syndrome, and you can see all of the extensive increased uptake areas here in the head, the axilla, in the chest here, some in the liver, all through the abdominal cavity here. And then that patient received the lutetium 177 therapy, and it's almost completely resolved. You see maybe a couple more places over here in the liver, maybe, and then also one there. And that's really it. So this patient had a pretty good response to the lutetium 177 therapy, but they did still have at least one area there. This would be scanned as become the patient's new baseline, but this patient would also need an FDG study as a baseline and to make sure that the tumor has not progressed at all. And that's all for this lecture. Thank you so much for watching this lecture on neuroendocrine imaging with PET-CT.